So thank you everyone for joining. I can see more people are joining as we speak now, but today is one of our free webinars, which we offer as part of a series that we're doing now, so that we can share with you the fantastic research that we're doing at NIHR Birmingham Biomedical Research Centre. So good evening, and I'm Laura, and I'm here to facilitate the talk today alongside our experts. So that's Professor Liz Sapey and Dr. Suzy Gallier, who are going to be talking to us all about saving our antibiotics and making sure that we understand a little bit more about what we can do to prevent that. But I'm not going to talk about that now, don't worry. They're the experts. But this is part of our series where we try and share with people in a more accessible way about the work that we're carrying out. And we hope that you enjoy it. It will be recorded. You can watch it again. You can tell other people about it. We'd be delighted if you'd do that. And we really welcome people's feedback. So that's one of the things that we'll be talking about in a minute. I'm going to move us on to the next slide now and just say, well, what exactly is it that you're doing at the NIHR Birmingham Biomedical Research Centre? So just give you a quick introduction on who we are and what we do there. So first of all, we're a collaboration between, there are a number of biomedical research centres, and I'll talk about that, but they're a collaboration between a university and a trust. So in our case, it's the University Hospitals Birmingham NHS Trust in partnership with the University of Birmingham, and our other partners who you can see here. And there's quite a number of them. And it goes wider than just Birmingham. We're publicly funded by the National Institute for Health and Care Research, which is the NIHR acronym that you might see in our name. And that's the research part of the NHS. We're not the only one. There are 20 biomedical research centres like ours in England working to improve people's health. So what do we do here? Well, at our research centre, we've got doctors, nurses and other healthcare staff working together with researchers to take take new scientific discoveries found in science laboratories and turn them into diagnostics, such as tests, procedures, and things that will help identify illness and injury and treatments. And our research specifically focuses on the causes of inflammation and the treatment of it. We know it's, a fairly common thing in many people. It's, part of the healing process. But, we've all experienced that. But sometimes it can become too much, the inflammation. It can lead to further problems, and it might be linked with further health conditions such as arthritis, infectious diseases, diabetes, cancer and gut diseases. So again, it's a really important aspect of it. Now, what we want to do is just hear from you a little bit more as well about the sort of things that you'd like to hear about. So that's why we would like to open up. There's a chat button, and it may be that you've got a black bar either at the top of your screen or at the bottom of your screen. It depends what device you're watching on. But just a quick reminder, because it's a webinar, we can't hear you normally. So what we'll do is ask you to put questions in the Q&A icon. Can you see that on your black bar? And if you pop those questions in, what we'll do, we'll have the talk and then we'll be able to address some of the questions that we have coming up. And as I said, it's going to be recorded, and so people that couldn't attend will be able to perhaps watch it afterwards. So without further ado, I'm going to now hand over to our amazing speakers. So this is a talk about safe antibiotics, understanding resistance and how data can prevent it. And over to you, Liz.
Oh, well, thank you so much for inviting us to this, to give this talk. I'm sorry you can't see either Susie or myself. You'll have to guess what we look like based on our voices. Please don't put anything unkind in the chat. So I am a professor of acute and respiratory medicine, working at the University of Birmingham and at University Hospitals Birmingham. And I work in acute care, and acute care is where most antibiotics are given out across the country and in the NHS and indeed globally. So, next slide, please. I'm going to start talking about what acute care is. And as soon as the slide comes up, there it is. It gives you a little bit of a guide. So if you start at the top left of this slide, you can see the question, what is acute care? Well, acute care is any unplanned emergency healthcare contact. It can be in primary care with your GP. It can be in secondary care in hospitals. And increasingly, it's given in places like pharmacy centres and sometimes in dentists. It is when you have a sudden health concern and need medical advice about it. And in the UK alone, there are about 300 million acute care contacts each year. The people that need acute care, and if we go down to the bottom, who needs it, is anybody with any kind of urgent healthcare need. And this could be something that comes on completely out of the blue, like an infection, or it can be a flare up of a known condition, such as an asthma attack. And the whole idea of acute care is to treat, to save lives, to reduce symptoms, and to make people feel better. If I move your eyes now to the center of this slide, the spectrum of acute care services, you can see that acute care is given in various levels of urgency, and that's how we classify it. There is trauma and surgical care. There's intensive care services where people need the strongest level of medical support. And there's urgent care requirements. And the UK's health system breaks down acute care contacts by these definitions. Now, commonly, we think about acute care in hospitals as being provided in the hospital for patients, and then it stops when people leave the hospital. But actually, we now provide acute care in lots of different settings, some which extend beyond the hospital. And some of these things you may have heard of. This includes things like virtual wards, where people are discharged home, but we continue to monitor them at the hospital by using devices that measure perhaps their pulse or blood pressure or oxygen levels. We also have hospital at home, where hospital doctors and nurses can come to people's houses and provide care for certain health problems that they have. And these sorts of different ways of approaching acute care are increasing. But the whole aim of it is to get people feeling better. And that means by trying to give them the right treatment at the right time. And the most commonly prescribed drugs across the entire health service and system are antibiotics. And that's what we're going to be focused on speaking to you about today. Next slide, please. So the reason we know so much about antibiotics and how they're used is because of how we utilize health data. And I'm going to talk a little bit about this now in the next couple of slides, but then I'm going to hand over to Suzy to talk about this later in a bit more detail. So every time you have a healthcare contact, be it an emergency one, be it with your GP, data about that healthcare contact is put into healthcare systems. And that data is used to help you get better by informing your doctor or nurse or any other healthcare professional what health problems you've had in the past, what medicines you've been given in the past, to try and bring together the best possible understanding of your health and its condition. But we can also use data for a different purpose, and that is to better understand how health services are being used across the country, what health challenges we face now and in the future, and what treatments might be the most effective. This is actually called the secondary use of health data. It's not being used to make a particular patient better, but we're taking data from lots and lots of patients, millions of patients sometimes, and bringing that together in an anonymized or de-identified way, which means nobody can see who the patient is, But by bringing that data together, we can understand more about the healthcare system and improve care for people across the country and beyond. And Pioneer is an acute health data hub that brings together data about symptoms, diagnoses, treatments, medical images, and from clinical notes into one centre, which is then utilised to answer health questions about our population, to try and understand more about the challenges we face. And Pioneer has been going on for 5 years now, utilising acute healthcare data. And we have used it to answer lots of different research questions. And one of the things that this brought up that we were asked to look at by the MHRA, our Medicines Health Regulatory Authority in the UK, was about antibiotic use across the country and how well we can understand what antibiotics are being used and whether they're being used appropriately. Because we know that when they aren't used appropriately, that can cause massive health problems. And I'll talk to you about that in a little bit. But it's important for you to understand how we know so much about antibiotics and their use, and data systems like Pioneer, bringing health data together from lots of different people across the country, is one of the ways that we understand health data. And I'll show you just one more slide about how we use health data before Suzy talks about it in a bit more detail later on. So next slide, please, Laura. So whenever you use data for any kind of purpose other than caring for the individual patient in front of you, you have to make sure it's utilised in the most safest way possible so that the data isn't misused in any way, it isn't used to disadvantage any members of our community, and that there is no chance of identifying the patient at the heart of that data, because we recognise how important health data is. So we use something called the 5 safes to bring health data together securely. That means that we have to have safe data. The data has to be de-identified or anonymized so that you can't tell which patients it refers to. By looking at the data, you can never tell who the patient is. We utilize the data on safe projects, meaning we have to make sure that by using data in this way, we're generating knowledge and understanding, which is there for the betterment of society. So it's there to help, not harm people. We only provide data access to safe people. That means the only people that have access even to this de-identified or anonymized data have to go through a very careful vetting process. And we also make sure that the use of the data has been approved by members of the public. The data is accessed in safe settings, which is the next one of the 5 safes. That means we just don't send out the data here, there, and everywhere. We provide limited access to it in a specific environment that the NHS control, called a trusted research environment, or a TRE. And we even make sure that the outputs of that data are safe. Every time analysis is done, we look at the data to make sure that definitely no one can be identified from it, and that the outputs, the work of that research, is going to help society and not cause any harm. So whenever we talk about data being accessed in order to understand more about antibiotics and their use, it comes through Pioneer, and we follow these 5 safe processes. And if you're interested, we can talk more about that in the Q&A if you would like to learn more. Next slide, please. But what we're, I think you've, that's it, skipped a slide. What we're really here to talk about today is antibiotics. And I bet there is not probably a single member of the audience or anybody in the presenting team that hasn't had an antibiotic for one form of infection or another. As I said earlier, antibiotics are the most commonly prescribed drug, not just in the UK, but globally. And they are vital for treating infections. Before antibiotics were readily available, the death rate from common infections was incredibly high. Higher than 50% of people would die following an infection, sometimes even more than that, depending on the type of infection that we had. And even diseases which we recognize from history as being devastating for members of the community, such as the bubonic plague, we now, if it came back again, could treat really easily with some simple antibiotics that most of you will have had, a simple penicillin-based antibiotic. Antibiotics have been hugely important in terms of improving not just the survival from infections, but also the side effects you get after having an infection. And they also enable us to offer other forms of therapy and treatment for people, because we know that we can deal with any consequences of it regarding to infection. So they enable safer procedures, such like surgery and cancer care, to be much safer. In cancer care, many therapies dampen down the immune system, which is the body's natural way of dealing with infections. And antibiotics are commonly used if people have an infection after a bout of chemotherapy for cancer. And they're often used after surgery, particularly if there's any wound infection. And there are some people who rely on antibiotics every day to keep going and to keep well. For example, people that have had their spleen out have to take antibiotics every day. But we know that antibiotics treat bacteria. They don't treat viruses or fungal infections. And so using them in the right place is really important to maintain their effectiveness. Next slide, please, Laura. So you will have heard about some bugs, some bacteria now becoming resistant to antibiotics. And we thought it would be important to explain how this happens. Some bacteria are resistant to antibiotics all the time, and certain bacteria are not susceptible to certain types of antibiotics. And the reason for that is a little bit related to what kind of bacteria there are and how antibiotics work on them. So, for example, some bacteria have a really thick, hard outer shell. And the way that some antibiotics work is when they are absorbed into the bacteria, they burst a hole through that natural thick coating, causing the bacteria to explode pretty much. But these antibiotics don't work on bacteria that have a soft outer skin, because that pore that they form, that little hole, doesn't have such a negative effect on them. Some other antibiotics work by joining with the natural DNA, the genetic makeup of the bacteria, and switching it off so that it can't replicate anymore, meaning that that antibiotic, that bacteria isn't able to grow through making copies of itself. But like every process, there is natural selection occurring, which means that some bacteria will be resistant to how the antibiotics work. And if a group of bacteria are given antibiotics, some of which are resistant to the antibiotic and some of which are not, the antibiotics will wipe out the bugs that are susceptible to that antibiotic, and the resistant ones will be enabled to multiply and grow. And that's what this picture shows here. So if you look at number one, the start, which is on the left-hand side, some germs are naturally stronger or resistant to antibiotics. Not all of them usually, but to a selection of them. And when we think about how we grade this, we either say that an antibiotic won't work because the bug is resistant to it, or the antibiotic should work because the bug is not resistant to it. But there's also something that we call intermediate, or in the middle, where the antibiotic might or might not work because there are some patterns of resistance in the bacteria. So if you give the antibiotic to a patient that has a number of different bugs in, moving to picture 2, the bugs which are not resistant to the antibiotics will be effectively killed. But those that are intermediate or resistant to the antibiotic will continue to survive and they will then multiply in picture 3 and grow more readily and then spread the way that infections do. And we think about spreading of infection with things like coughs or sneezes or through blood. But some of these bacteria can also survive and spread in things like soil, on plants, and in the environment. So if the resistant bacteria get out, there are lots of ways that they can continue growing, and they will then be harder to treat because there will be more of the bugs that are resistant to that antibiotic. Next slide, please. And we know that this is really important. The prevalence of resistant bacteria or bugs, meaning the number of them out in the world, is growing dramatically. And this, we think, will have an impact on everybody's health if we allow this to continue. Firstly, we won't be able to treat infections as effectively, meaning longer periods of illness and longer hospital stays. That's because if antibiotics don't work effectively, infections can last for longer, often requiring extended stays in hospital. 2, we know that if there is a lot of resistant bugs around, common medicines, they no longer work. So at the moment, amoxicillin, which I bet some of you had, which is a penicillin-related antibiotic, is one of the ones that's most commonly used because it fights a lot of infections, particularly ones that are very common in this country, such as pneumonia, lower respiratory tract infections, that's infections in the lungs that are a little bit short of pneumonia, sore throats. But if those don't work, we will have to use more complicated antibiotics, some of which can only be given via a drip therapy, meaning people would need to come into hospital. And 3, we know that if antimicrobial resistance continues to grow, if these resistant bacteria continue to become more common, infections will have a higher risk. That means we might see more people dying of infection. And it certainly means we'll see people having more side effects from infections, such as bad scarring to the lungs after chest infections. And that used to be really common in this country before antibiotics were commonly available. We don't see that so much now, but the worry is all of these things will come back. Next slide, please. And this slide looks quite frightening, but it's really to put into context what we expect to happen if we aren't able to tackle antimicrobial resistance. So if we can't stop the number of bugs around that are resistant to antibiotics. And this slide is divided into half. The one is looking at the human cost, which as a doctor myself is something that I am most focused on. But there's also the other half of the slide looks at what this might mean to the economy. So the human cost first, which is on the left of the slide as you're looking at it. Well, firstly, we think there would be a huge loss of life. We already know that people are dying now because of antimicrobial resistance. And in 2019 alone, there were 1.27 million deaths caused directly because the antibiotics we have available weren't able to treat the infection because of antimicrobial resistance. So sometimes this is spoken about as a problem for the future, but I wanted to highlight that there is a really big cost to this now. We also know that people might not die directly because of that infection, but they have died because of things associated with that infection. So, for example, they may have had an operation because of an abscess in their tummy or an infection there. And although the infection was cleared because the antibiotics weren't working and because they had complicated surgery, they unfortunately passed away. We think there was another nearly 5 million deaths associated with antimicrobial resistance, or where it was felt that this was going to be a contributory factor. And we now know that antimicrobial resistance, because we've been able to look at data with organizations such as Pioneer, claims more lives annually across the world than malaria or HIV and AIDS. So it is a real problem that we need to tackle. Now, if I ask you to cast your eye to the right-hand side of the slide, you can see what we expect to happen in terms of costs. And you can see there are some pretty big numbers there. So by 2050, which isn't that far away now, we think that there'll be an extra £745 billion needed to cover the cost globally of antimicrobial resistance on top of what the world spends on healthcare now. And we also know that because people either won't be able to work themselves because they're unwell, or they won't be able to work because they're caring for people, it's going to have a huge cost on the global economy, thought to be £2.5 trillion annually, if we allow things to continue as they are now. And that's because not only does it cost a lot to look after people if they've got an infection by a bug that is resistant to antibiotics, but it also stops other people from being able to work, as I said, because of that sort of care that people have to give if a family member is unwell and needing support. Next slide, please. So if you weren't now fully committed to knowing that antimicrobial resistance was a problem, and I hope I'm not terrifying people, we projected in the future to say, well, what would happen if we completely ignored the situation and just carried on using antibiotics as we were now? Well, today, at the left of the slide, you can see that we have a very safe way to do medical procedures and to look after patients. We're able to look for the bacteria that people have, give antibiotics quite freely, knowing that they'll kill most of the bugs that are out there. And that enables us to do treatments for people as they need to, without really a worry or a concern, particularly in the UK, for antimicrobial resistance. But looking at the slightly scarier right-hand side of the slide, you can see if there was widespread antimicrobial resistance, routine infections could become life-threatening. Even simple operations that you would have done now without too much thought or worry would become really high risk. And our treatment options that we could give to people would be severely limited because of the impact of antimicrobial resistance on health. But of course, we're not going to take this line down. And there's a huge amount of work that we're doing in order to understand what's driving antimicrobial resistance and how we can better target antibiotics. And I'm going to talk about that now. Next slide, please, Laura. So the way we used to identify infections, and in some places still do in the UK, is by plating up bugs on a plate, an agar plate, seeing what grows, and then individually testing antibiotics to that bug to see which one it's susceptible to. So which ones kill the bugs and which bugs are resistant to certain antibiotics. Literally, it's done by taking a plate, growing the bacteria up into little clumps, and then dropping antibiotics onto them and going, oh, yes, amoxicillin, a common antibiotic, has killed that one. That's not amoxicillin resistant. You could use that for the treatment. Or on this particular cluster of bugs, the amoxicillin hasn't worked or helped at all. So this one must be resistant to amoxicillin, an antibiotic. We won't use that one. And that process takes days. And because we can't wait for that process if people are unwell, what we end up doing is giving antibiotics what we call empirically. That means going, I think this patient is unwell with an infection. The evidence suggests this is a pneumonia, for example, or a urinary tract infection. The most common bugs we know about that cause these types of infection are these, and they are usually sensitive to this antibiotic. So we'll start with that one. And then the results might come through 3 or 4, 5 days later, either saying, oh, yes, that's worked, good, or, oh, no, actually, that bug is resistant to that antibiotic. Please don't use it. And Of course, then you might change treatment. You might have noticed that the patient wasn't getting better and changed the treatment before that, but it is a little bit hit and miss. So in our BRC, we are driving a new technique called clinical metagenomics. And I'll explain what that is now using this slide. Essentially, we use the DNA, that's the genetic makeup, or the RNA, the proteins that the genetic makeup makes from bacteria or viruses, and we look at them all. So if you start in the how it works box, you can see there's a little flask. We extract the DNA or the RNA, the genetic code, from samples taken from patients. And we put them in a machine that can sequence every single bit of the DNA. Now, because we know what the genetic codes are of most bacteria and viruses, we can then identify all of the different viruses or bacteria that are in that sample, or we can tell if there's no bacteria or viruses there. We can list them so we know which ones are present in the largest numbers. And we can also look at what resistance genes the bacteria or viruses have within their genetic code. And we know which resistance genes stop different antibiotics from working. So very quickly, you get a readout that either says, I know someone presented with a fever, but they don't have an infection, or they do have an infection, but the infection's a virus. Now, knowing that quickly means that in those two scenarios, no infection or a virus, giving an antibiotic isn't going to help because they only work against bacteria. And if it is a bacteria, we can say from the genetic code, we can tell that this bug is going to be sensitive to this antibiotic. So that's the one to use. It's not going to be sensitive to these ones. And so what you can do with this is, first of all, you can diagnose new illnesses. This is exactly how we found out what COVID was. Lots of samples from patients that were unwell with this new bug, starting in China, ran through this process. It identified a new type of coronavirus that we hadn't seen before. And we could then share that genetic code across the world so that everybody could start to look for it in the samples they were getting, enabling us to track that virus. It also enables us to predict antimicrobial resistance. So we can look through and say, right, actually, if we look at all of the data from the West Midlands, we can see that there is a new type of a particular bug that we found that seems to be partially resistant to this antibiotic. Please don't use that antibiotic because we don't want the bug to turn into a superbug to be resistant to lots of antibiotics. So use this one instead. So we can use it not only on the individual infection and the sample, but we can use it for surveillance, for monitoring infection really across the UK. And we can also track disease outbreaks. And I think we were all used to looking at the COVID slides in the evening. Even me, when I got off work from a 12-hour shifts in the hospital, always tuned in for the news to see what was happening with COVID. You can use it to track disease outputs. And we are testing this new technique called clinical metagenomics, identifying bugs and resistance patterns through their DNA, RNA, working in conjunction with hospitals across the West Midlands and the University of Birmingham. It sounds great. You can do it quite quickly. So the kind of information that you might get in 5 days, we can get in a few hours. But there are a few hurdles before we can get it into clinical care. And that's what we're working on now and utilising Pioneer data for. So first of all, the hurdles that we've identified is the amount of signal you get versus noise. That means because it tells you everything that's in a sample, trying to understand what is the true cause of the infection is quite complicated. At the moment, it costs a lot of money to do each sample. So we're trying to find cheaper and cheaper ways of getting the same technology available so that you could have this done whether you went to your GP with a simple urinary tract infection or a chest infection, and you weren't having to go to a very modern hospital to get this done. And we also know that sometimes when you're looking at the genetic signal for the bug, you can see some human genetic signals in there. And what we don't want to do is genetically code people as part of this process. So there are some ethical dilemmas and some privacy dilemmas that we're working through as well to try and make sure that this is as safe as it possibly can be, both in terms of how we use antibiotics, but also for them how we can support patients, because we don't want to find out anything about them that they didn't go into knowing we were looking for. As I said, the main real improvements this might bring is, first of all, it could tell us if there wasn't an infection, so you wouldn't have to give antibiotics. It would tell us within a matter of an hour or so whether it was all viruses, so antibiotics wouldn't be helpful. And it can tell us what the bug is likely to be and what antibiotics used. But we've got quite a lot of work that we're doing as part of our BRC theme to really see how we can embed this into normal clinical care. Next slide, please, Laura. So I'm now going to hand over to Suzy Gallier, who can introduce herself so that Suzy can talk through how we're using data to try and improve how we use antibiotics and how we use clinical metagenomics. Suzy, over to you.
Thanks, Liz. And again, you'll have to imagine what I look like, and I won't look in the chat to see what you say. So very much now focusing on the data and the health data research side of things, and being a sort of data guru and nerd myself, this is the bit that I'm sort of really passionate about, and I'm the technical director in Pioneer, so very much focused on bringing that data together and ensuring that we do that in an ethical and transparent way. So data is a very powerful tool, and if we go to the next slide, I can talk you a little bit through this. So how are we going to deliver this precision that Liz has been talking about? How are we going to sort of use this data? So precision in healthcare means, and I think Liz has already said this before, but it is about giving the right treatment to the right person and at the right time. And that's important because not every patient benefits from antibiotics in the same way. Some people need that urgent treatment and others will recover without antibiotics. And it's that data, and at the top left-hand corner, you can see that what we're talking about here is bringing GP data, ambulance data, hospital data at a national scale of antibiotic use and the outcomes of that, so that in the middle you can see that sort of national map of how we are seeing those trends, and we can learn from those patterns. And by looking at large numbers of real patient journeys, we can start to see patterns. We can see which combinations of symptoms, observations, or test results are linked to deterioration or resistance. As Liz has just explained to you, we can also use that genetic level data to understand what bugs are present and which medicines are more likely to work. And that's all done very robustly with data. So what that means is that we can start to work with clinicians like Liz and her team to say we're more confident in the patterns we're seeing to enable them to make more confident decisions in their clinical practice. On the bottom of the slide, we're just reminding you of those numbers that Liz spoke to earlier, some really significant global impact if we're not going to do anything. Okay, next slide, please. So really want to just touch on the fact that this is real patient data, and people often ask us, well, how do you actually protect my patient data? And hopefully we'll be able to give you some assurance. Data used for research is not handled casually. We take this very seriously. It's something that we protect by several layers of rules. We use technology, and people like myself as technical director and pioneer provide that oversight and reassurance, and we link with our patient and public members very often about this. The data on the left-hand side, you can see it's anonymized, so the researchers are not going to see names or addresses. They are working in the middle in that very secure area. It's protected by lots of different technologies, and it's monitored and controlled. And as Liz talked to, those projects go through a lot of information and checks. Sorry, we're moving the slides. Can we move back to next slide? Yeah. And so in effect, we've got lots of checks and balances in there. And all of that is done with an ethical framework to make sure that we follow those rules and govern ourselves properly to make sure that what we're doing is ethically secure. But all of this is about the learning from patterns. We're not looking at individuals, we're looking at a big group to look at patterns and improve care across the NHS whilst we respect privacy at every step. Okay, next slide, please. So we've got our sort of pretty journey here across turning those sort of patterns into decisions. So when data is analysed at scale, it helps us, the NHS, respond earlier to emerging problems. For example, like Liz explained earlier, if there's a resistance to a certain antibiotic is increasing, we can detect that sooner through the data rather than those individual cases alone. This information then can be used to update the prescribing practice used in our acute care and beyond, in broader sense in GP practices and hospitals. We can target our training around this and we can adjust our pathways of care to make sure that we're flagging those risks a lot sooner. But the data also allows us to check if that change has worked. So we can look and say, well, has that happened? Has this improved? And actually, if things change or drop, then we can actually measure it and change again, and we learn in a sort of cycle. So in this way, the data supports not just the initial research, but also those continuous improvements. Okay, next slide, please. So as the technical person on here, it would be remiss of me not to touch a little bit on artificial intelligence. And you'll hear a lot about artificial intelligence in healthcare. And sometimes we know that as members of the public, you might sometimes feel a little bit worried or uncertain. But in this setting and the work that we're doing with the University of Birmingham, the hospital and the Biomedical Research Centre in Birmingham, we're making sure that this is not about replacing our healthcare workers, our doctors, our nurses. It's about supporting them. We're putting tools in that mean, especially in those busy acute care environments, that we're using that artificial intelligence to provide real-time evidence around our antibiotic prescribing so that then they can see what treatment it's suggesting. But ultimately, the decision rests with the healthcare worker. So in hospitals, clinicians are often managing many patients at the same time. There is a large amount of information generated from the observations they take, the blood tests, the scans, the past medical history. And AI is able to collate all of that information in that sort of iPad picture in the corner, and it will really take all of that information at real time, and it will be able to use data to actually look and provide real evidence-based feedback to our clinicians. So it's helping them in their clinical decision. It's a clinical decision support tool. It's not a doctor. And what matters here is that it highlights a risk, but the clinician is still the one making that final assessment and prescription. And used well, these tools can. The evidence is there in research, and this is why we want to build this even more into our systems. They can help reduce delays, they can reduce missed warning signs, they provide just some safer, more timely support to busy clinicians, but they're that extra layer, they are not a replacement. Next slide, please. So we've talked about this a little bit already, but this is about if we can get that right treatment sooner, patients should recover quicker, and the data that supports this means that we can then understand and avoid those unnecessary strong antibiotics. So we will reduce the harm and side effects to the individual patient, but using that data at scale to really understand what we are recommending. But on the other hand, if they fail due to resistance, the care becomes more complex, and we've heard that then the treatments and the recovery is slower. So all of this is about why it's important that this data is used to make sure we get the decisions right and we actually provide the right treatment at the right time. Okay, next slide, please. So smart antibiotic use, and we're trying to sort of bring this together now to sort of say, well, there's a role for us all to play here. from the clinicians like Liz in terms of how they're engaging with us and the data, and Liz being sort of leading the pioneer team, me in the way I'm bringing that data. But then as a public, what can we also do to help this? And so this is about how we all protect our antibiotics. And so some of the simple actions that do make a difference. So taking antibiotics only when they're prescribed for you, and to follow that advice that you're given and how and when to take them. So making sure that if you're given a course of antibiotics, you do finish them. And also not to ever share or reuse those antibiotics. Don't keep leftovers. Make sure you do finish them. And also, as always in healthcare, we do suggest that if you're not sure, do ask questions. You can go to your pharmacy and ask those questions. Is it something that you want to sort of have just that some reassurance about? It's much better that you have these conversations to make that shared decision making, and that we really sort of understand the use of that medicine. So it is really important. So bringing it all together, I want to end on a more positive note. It is preventable and they are precious. It is a serious problem, but it's not an inevitability. If we are looking and using our data with careful prescribing, with our, in making sure as patients and public you're informed, and use that health data to really bring the sort of intelligence with all of the latest tools that we've got. Liz talked about how with the metagenomics, with our AI intelligence, we can really use that health data to slow this down, and we won't then, and we can avoid those numbers that we saw on that screen earlier, those sort of trillion numbers and millions of deaths. So it is something that we believe, and Pioneer is very much supporting the data analytics side of this to make sure that we can really secure the future of modern medicine. Thank you. Is it back to you now, Laura, I presume?
It is indeed. And we seem to have a bit of a satellite delay over this end as well. But thanks very much for that fascinating talk. Lots to think about. And I know there've been quite a few questions already cropping up in our chat. So what I'd like to do is say thank you very much for all of that. I know that you wanted to acknowledge Pioneer and all of our colleagues. We'll talk about that at the end, but if I can just pose some of these questions to you and fire away and pick up whichever one of you think is relevant to answer it. But I am going to start off about the data. We've had a really interesting question. And thank you very much for posting this, everyone. What systems are in place to minimize hackers to access the data?
I think I'll pass that over to Suzy to answer, as she is a self-confessed technical geek. So Suzy, over to you.
Absolutely. So we take security very seriously, and we actually work as the NHS. We already have a lot of security measures in place, but given this is research data, we've brought in some Ministry of Defence professional hackers who actually then work with us to really test our system. And I'm very pleased to say we get tested very frequently, and they have advised us how we keep that system secure. So it's lots of different tech that we use, but we also bring in people who are responsible for our national security to further, tighten the security there. But we always get the green light around our security measures. But it is an excellent question.
Yeah, thank you very much. I have got a slightly longer one now. The person says, I feel really positive about data being used for health research. One of the questions I've heard people ask is, what about data where the granularity is so detailed that cohorts are small and so people could be identified? I'm supportive, but like an answer as a rebuttal to this question. It comes up particularly when patients with rare diseases or infections are used.
Yeah, absolutely. I'll start and then I'll hand over to Suzy to talk about it technically. You're absolutely right. There are some conditions that are really rare, where we know that maybe even only a few handful of people have that condition across the UK. And we also know that if you make data detailed enough and an example of that. You refer to it as granularity. That's the term we use. But for example, if you were to say that we had somebody in the hospital who was over 100 years of age, well, there aren't very many of those, who was from a rare ethnic group and who came in with a combination of a number of health problems on a certain day and who died, unfortunately, on a different day. If you gave that information together, it wouldn't take very much for people to be able to identify the person at the heart of that data. So we deal with these in different ways. For rare diseases, we try and expand our net. So we bring together as many people as possible with that rare disease. If the numbers are still low, then we reach out to people with that rare condition to ask if they're happy for their data to be utilised. So we ask their consent. But sometimes, if you look at data from the UK and other healthcare systems that are similar to ours, like the Dutch one, for example, you can get numbers up to a level where it's unlikely the individual patient could be identified from it, particularly if you remove location data. So if there was somebody with a very rare condition and there was only maybe 2 people in the West Midlands with that condition, but a few more down in London, a few more elsewhere, you wouldn't identify those 2 lines as being from the West Midlands. And actually, we suppress the number of really fine data details that we get, so that as a researcher or someone looking at that data, it becomes really hard to identify them. And Suzy, I don't know if you want to give a few more details.
Thanks, Liz. So, I mean, excellent. I mean, the main thing to say is that we have a lot of procedures that mean we have algorithms we run on the data to identify this. And then on a case by case basis, that's what we look at. We look at how identifiable is that data, and then we can suppress, as Liz says, in different ways. But we've got lots of technical approaches to ensuring that we don't risk re-identification, and it goes through a number of checks in terms of quality assurance and data sign off. But equally as well, sometimes what we're able to do is create synthetic data as well to actually increase the numbers in there, which means that we can combine the two. Now, sometimes that isn't always appropriate, but there are, as I say, it's very much a case by case basis, but as Liz said, we take it very seriously to make sure that patients are comfortable that they are not going to be re-identified in that data.
Yeah, thank you. And perhaps sort of related to that, I've got another question, which is, are you seeing antibiotic misuse and or resistance in any particular UK communities, or of identity or geographical areas?
So in some aspects, it's quite common, and it doesn't seem to be located to particular areas or communities. So I think there is an expectation from the public, and I have a lot of sympathy with this, that if you have an infection, antibiotics will help you. And even if the infection is most likely to be a virus, so antibiotics won't help, sometimes patients can put a little bit of pressure on healthcare staff to get antibiotics. And if you've got a really short appointment time and you're working under pressure, sometimes the easiest thing for a healthcare professional to do is go, well, okay, then have the antibiotics, even if you feel they won't work and they're not needed. So really, preventing antibiotic misuse in this way has to be done in different ways. First of all, we need to really work with members of the public to help them to understand what types of infection are more likely to be viruses or not need antibiotics. Some viruses can make you feel really unwell, and people then might think, well, I am feeling horribly unwell, I must need antibiotics. But I don't know, for any of you that have had flu and been really bowled over by it, it is quite common to feel terrible with some viruses for a while, and having a course of antibiotics in that situation wouldn't help at all. So we need to work with members of the public so they feel better equipped to understand what could be a virus and what is likely to be a bacteria. And we have to help our prescribing community, and that's most commonly doctors, but not just doctors now. Some advanced nurse practitioners can prescribe, some pharmacists can prescribe, so that we all know actually that even though it might feel easier to say yes, it isn't going to be helpful in the long run, and it actually could be quite harmful for us in the long run.
Thank you. Some people have asked some questions about that, and hopefully they feel it's been answered. Something that's cropped up is about the name of Pioneer. Is it a lengthy acronym or is it just a name? And also related to that, is it a tool? So is Pioneer a tool that's exclusive to University of Birmingham's Biomedical Research Centre, or is it used across the NHS?
Yeah, I'll start, and again I'll hand over to Suzy for a more technical answer. It is a very long name, based on how we can use health data for the good of the population in acute care. But the reason we kept with Pioneer is because what we were doing was, and remains actually, quite pioneering, in that there are lots of data sets, lots of data being brought together for specific illnesses, rheumatoid arthritis, for example. There's a massive data biobank on that, certain cancer types. But there was nothing that brought together data from those urgent healthcare contacts to understand them in a bit more detail and to understand what was going on, irrespective of what condition people had and what happened to them afterwards. It was also quite pioneering to work not just over GPs and hospital data, but also to bring in ambulance data. So we look at the whole journey of people when they're unwell. And it isn't just a data resource, it isn't just a data set that people can use. We also have a lot of technical infrastructure to go around that as well. And we have associated with Pioneer a patient and public group called our Data Trust Committee that review every request we have for data. And 80% of that Data Trust Committee have to approve the data use. And if it's a no from the Data Trust Committee, because 80% of them aren't positive about the data access request, then data access is denied. So by bringing patients into the heart of those data access decisions, we can make sure that we're always on track to be focused on public good. And then Suzy, do you want to talk a little bit about the technical infrastructure?
Thanks, Liz. So again, I spent some of my career working in industry, and so very much wanted to make sure that what we were offering our researchers across our sort of, not just our Midlands community, but nationally and beyond, was something that was really cutting edge. And so we have worked very closely with very sort of industry-led technical experts to build, as I said, a trusted research environment where that data, we use cutting edge software to make sure that the data is ready for researchers in a really accurate way. But we also have that secure environment that has all of the latest tools available for researchers, whether they are doing what we would call more sort of analytical statistical work, or whether that is then more advanced data science using large AI models. And we work with Microsoft Ninjas as well to sort of really provide an absolutely cutting edge infrastructure, but also balancing that up with cost to make sure that we aren't sort of charging large amounts of money for sort of the time that the machines are running. So we were always trying to balance out that. But Pioneer itself stands for it was precision informatics to optimize emergency care research. So it's all about precision data and sort of that emergency care environment. But we're very proud of the technical infrastructure that we've created and worked with our industry to design that, but also with our patients and public to make sure that they were comfortable with the levels of security that we've put in.
That's brilliant. Well, thank you very much for taking time to answer those. I'm sorry, but we are really short of time now. And I'm going to have to end this in a couple of minutes. But really appreciate that. And there have been a number of questions, some of them related, some of them very, very detailed. So again, I suspect at some point we maybe ask you to come back and do more, and we'll use those. But again, using the feedback forms from people will be really helpful, isn't it, for people giving us ideas about what they'd like to know more about, because it's a big subject. Thank you so much for giving us that talk. And I wanted to say, you've mentioned about Pioneer and how we involve patients in that in that, and they are very much part of it. I just want to tell you, everyone, a little bit more as well about the sort of things that you could do as well. For instance, you could get involved with us you could be part of research. It might be that you want to take part in a clinical trial or study, perhaps something like this. And again, if you want to do that, there's links that will be posted in the chat, I believe. And we've also got information there. You could just type in, be part of research, and look at the NHR site. We are so grateful for all the people that we are working with at the moment, who decide that they want to give it time to help us and work with the research as well. And here's some of the pictures of things that we've done, which have been amazing, sort of engaging with people and making sure that we have real recognition of that lived experience, which is truly different, because it can make that difference for a researcher to really understand what it's like to have that particular condition or think in a particular way for a community. So if you want to do that, again, just let us know, complete the form. We're going to put that and email you. So again, you could do that, and we would really like you to get perhaps involved from the very start of the research that we're thinking about. In fact, you might influence what research we're doing by helping to shape that. So that would be brilliant if you want to think about doing it and you want to find out more. Some of you probably are already, and perhaps in a different centre. So again, it's always good to learn. And talking of learning, we've actually got another of our series coming up, and that's going to be in March, by Professor Simon Jones. So one of our themes is talking about obesity and osteoarthritis. Can weight loss drugs help beyond the scales? And again, if you'd like to attend that one, we will put the link, to the how you do that, like you did for this one, in an email to you, where we send you a link from this as well. So thank you to Becky in advance for doing that. And that sounds really interesting, but the main thing that I would like to do now is say thank you very much to our speakers. Thank you for Becky and the rest of my team for supporting with this. And thank you all for giving up your time this evening to make it really interesting and to put some great questions there. And thank you very much. Been great seeing you. Have a good evening. I look forward to hearing from you very soon. Bye-bye.